No? All right, let's go over the slides for today, and if you guys have any questions, let me know. We can go on. All right, we'll talk altered mental status, confusion, mostly delirium and dementia today. So, what do you guys think about when altered mental status pops in your head? Meningitis, good. What else? Hypoglycemia, good. That's a good one. What else? Drugs, alcohol. What did you say? Airborne. Okay. Concussion, nice. What else? Anything? You're patient zero. What are you bringing into this room right now? You all right? You sure? Everybody, positive feeling vibes your way. Yeah. All right, I'm just kidding. I hope you feel better. It's not fun when you feel better. You feel sick. Stay over here. All right, what else? Anything else? So the differential is wide and vast, just like what we talked about yesterday with disequilibrium. So, and some of it's overlapping, right? So you guys told me some of the things yesterday when I opened it up to the group. I think I heard some CNS or metabolic derangements, right? So we talked about a lot of those. So, all right, we'll talk about this, and then we'll move kind of forward, and then we'll go from there. What's your next test? Pharm?
Ortho.
Ortho?
Pharm's Monday.
Ortho 2? Oh, you guys are good, right? What's Ortho 2 on?
Upper extremities.
Come on. Only so many things you can ask, right? I didn't preview that one ever since I've been here, so I don't have any dirt to give you guys. He added 100 slides? We'll talk to him about that. Alrighty, TLOs, ELOs stay the same. So really delineating between the two is what I want to target this this discussion on. So when you look at altered mental status or confusion, right, it's kind of vague. For our intents and purposes, we're going to boil it down to really delirium and dementia. And I want you guys to compare and contrast those two as we move forward. Different things can cause them, right? It's not one or the other. There could be some overlap. But as we learn this and we discuss it for today, think of them as two separate constructs, right? So that should make sense. My neighbor has dementia, right? I think I told you guys about my neighbor across the street, retired 06, Alzheimer's disease, rapidly progressing. But can he become delirious as well? Yeah, right? And those are the tricky patients, your patients that come in with a history of dementia but now are septic and delirious. And that happens all the time, nursing home patients. Urosepsis. Whatever the sepsis cause is, we got to figure that out first and hopefully fix that. So, all right. All right. Let me see. What else do I want to say? There's not more to say that. So, approaches, right? You may not be able to get information from the patient that should just make sense. They may not be coherent enough or making sense, rational enough for you guys to elicit any true feedback from them. So 3 important pieces of information: the baseline cognitive function, the time course, and any current medication. So baseline cognitive function, what were they like this morning? What are they like at baseline? So I see a lot of folks that come in that have a history of dementia, and they already have, like, their baseline is A&O times 1 or times 2, right? So I see them and I'm like, damn, something's off here. And it's kind of a strange question to ask a family member, but like, what are they like typically, right? And like, I had one of my first hemorrhagic strokes was a 96-year-old lady that just was staring at me. Like, I felt like she was in there, but she wasn't saying anything. And I would act like, I walked in, EMS dropped her off, and I'm like, what's going on with this patient? There's a stack of papers. They did a handoff with the nurse. It was a temp nurse that was already off to something else. And I'm like, hey man, what's going on? She's just bug-eyed, staring at me. Can you hear me? Can't move. Can you blink your eyes if you can hear me? She's blinking. Follow my finger. She's following my finger. And I'm like, huh, interesting. Can you squeeze my hand? Squeeze my hand. I'm like, huh, alrighty. What do we know about this lady? Oh, yeah, she got dropped off by EMS. They said she's altered. And I'm like, well, what's she normally like? I have no idea. Like, did they tell you? Nope. They didn't really give me much information. But here's her medical history. It was like the Bible. I'm like, that's fun. Daughter's en route, daughter gets here. What's your mom like typically? oh, we're having tea this morning. Like, she was making sentences this morning? Like, yeah, she was making perfect sentences. Why? What's wrong with her now? I'm like, oh, nothing. We're working her up. So thank God I had the, like I said, we make you guys, we build into your head through iPad that you're going to have to remember all these labs and studies to order. I'm just going to tell you the truth. Like, I go into my EMR and click altered mental status, and there's a drop down set. Like, this lady seems altered. Let me click this one, right? Like, sometimes throat clocks right twice a day. So then they call you back, like, hey, Rogers, come to the front. Radiology wants to talk to you. What's up with your lady in 6? I'm like, I had no idea. She blinks. That's about it. But yeah, well, she's got a massive brain bleed into like her right, ventricle. I'm like, oh shoot. I'm like, oh, it's on differential. Like, oh God. So, and then her age, advanced age. I talked to neurosurgery. There's not much they may have drilled an EDD. I'm not sure, but nothing that we did there. Just her blood pressure and really seizure prophylaxis was all I had to worry about. But anyways, baseline cognitive function, time course, is it slow, incremental, or is it fast, right? So you think, typically speaking, slow declination of your cognition. What do you guys think about? Usually Alzheimer's disease, which is the most common form of dementia in our society. So like mostly you think dementia as opposed to rapidly onset. Stroke, yeah, delirium, right? So some sort of infectious etiology that's making me lose my mind. So meningitis, somebody said earlier. So you'd have to couple that with now fever, nuchal rigidity, headache, blurry double vision. So all those things you guys should be thinking about. And then current medications to just make sense. Like what are they taking? Oh, nothing, right? Are they on any meds? No. You look in there and you're like, oh, they're on psychotropic medications, not to mention the bag of meth that they had with them, right? So all the goodies, those type of things are going to convolute your physical exam and your patient presentation. Just assume they're taking meth at this point. So well, that was work though. We should have invited him in and tried to get him to give us some sort of questions. Did he already do a review?
Yeah, he did a review.
Was it good?
Yeah.
Yeah. All right. All right, past medical history, right? Obviously PMH, and these should make sense, right? So cardiovascular disease, favor stroke, DM, high risk for stroke and everything. Seizure disorder, head trauma, alcohol, drugs, psychiatric history. Those should kind of make sense. Why psych history?
They're always like that?
Yeah, that and see medication side effects. Are they off or on meds? So again, I found that most of my patients, most of my schizo patients that come in or bipolar 2, like won't openly tell me that for some reason. You'll have to chart biopsy and figure out the meds they're on. Do you have any behavioral health history? Nope. What are you taking Haldol 3 times a day for? Oh, schizophrenic. I'm like, huh. Did I not ask you right? Like, or the best part is in phase 2 when you guys get this thorough, great ass history, or great, history from somebody, and you go in and then the doc asks the same question, your preceptor, and they just answer totally different. And you're like, I asked past medical history, they said nothing. And then he asks or she asks, and they're like, where do you want to start? And you're like, what? What didn't you understand? But we expect that anyway. So patients do that, not on purpose, all the time. So physical appearance, right? General appearance, lethargic, or ANO times 4, the stuporous. Vital signs can tell us a lot. Febrile tachycardia, right? Those are Sears signs or systemic inflammatory response. Skin rash, we miss 100% of the things we don't check for, right? So that purpuric rash, right? So check for that. Make sure we're looking for any type of bruising or petechiae or purpura. Head and neck stiffness we talked about with meningitis, and then chest, abdomen. Like, do they have an acute issue going on, right? So you think chest and abdomen, that's strange, but could they get septic from a pneumonia? Could they get septic from a ruptured appendicitis? Sure, right? We need to look at the totality of the patient. And again, head to toe exam, right? Usually after your primary surgery, you'll do secondary surgery. So MMSE, I won't plug this too much, but just like the video in the front, if you guys are consulting neuro or consulting medicine for altered mental status, do an MMSE. Like, it's so easy. I'm even trying to meet you guys halfway. Don't memorize this. Like, don't memorize this. Just have it on your phone and just take it up and ask them the questions and then score it. So when they ask you, if neuro's like, what was their MMSE? You can say, oh, it was like 10, right? And they'll be like, damn, you did an MMSE? Like, you're an all-star, right? As opposed to saying, like, they're altered because they're acting weird. People can be weird too, right? Present company included. All right, remembering that less than what is concerning? Yeah, right, in 24. Can we do this serially? Can I track this for you if I think there's a decline in your mentation? Can I do this like when I first see you and then 3 hours, 12 hours later to track this, make sure we're going the right way, getting better, staying the same, or getting worse? Yeah, absolutely. It's easily reproducible. That's the beauty of it. I'm not sticking a huge needle in your back every time, which is fun. Don't get me wrong. I'm all about doing an LP, but this I just have to ask you a couple questions and be like, you came in and you were scoring 25. Now you're at 15. Now you're at 12. Something's wrong here. Something doesn't make sense. You're getting more and more confused. And again, these are things we're looking at with that. So I'm with the MMSE. So I'm not going to kind of drill down on these too much. Different types of aphasia: global aphasia, conductive aphasia. So there's transcortical, motor, and sensory, which we know as Baroque's and Wernicke's. Do you guys remember those? Yep. And then there's subcortical aphasia as well. You guys mind? This is kind of extremely rude. Can I just take a phone call real quick? Yeah. So a couple things on memory. So 3 different types of memory. So we talked about this last block, but working memory, less than 30 seconds, 7 bits of information. Vulnerable to distraction. So you can assess this by repeat after me, right? You can't teach an old dog new tricks. Or something that I think about, 7 to 10 bits of memory, like a license plate. Like if someone crashes into you or throws a bottle at you outside their car window, first thing you just try to look at their license plate and memorize it, right? So that's your working memory. Same as like a phone number. Someone tells you their phone number and you try to memorize it. That's working memory. Okay. A little bit on the anatomy. It's related to the RAS, right? So reticular activation system, prefrontal cortex, and the parietal lobe. I think that's interesting. Of course, this is anatomy. That's why we're mentioning it. But I would like you guys to know the difference between working, episodic, and lasting memory. So episodic lasts minutes to months, even years. This binds information about the what, when, and where. Lays down significant memories, okay? And this is related to the hippocampus, dorsal medial nucleus, or the thalamus, okay? And it's affected by thiamine deficiency. Where do we see thiamine deficiency a lot? Alcoholics, good. So we'll talk about that a little bit later, and that's going to come up because we're talking about altered status. So again, you can do your MMSE, and remember, we'll have them repeat something right away for that working memory, and then at the end of the exam, we're going to say, hey, I told you to memorize something and repeat it. Well, what is it? Tell me it now. And that's 3 to 5 minutes later. Now we're testing their episodic memory, okay? And then your lasting memory, lifelong memories. This is related to your anterior temporal lobe and your frontal lobe, or your executive headquarters. So this is like childhood memories, stuff like that. Like mom and dad chasing you around the house, beating you or something, I don't know. Telling you to eat your dinner, whatever it is. Hopefully they're happy, they're not sad. I don't know why I went that route. All right, executive function, so mental activities involved in planning, initiating, right? So this is your frontal cortex, okay? This is the central organizing function of the brain. I think we kind of all know this. Decision making, higher thinking, which you guys are all using right now when you're in IPAP. Hopefully you're doing some of that critical and creative thinking. So, historical red flags. So for our altered patient, progressive declination with that neuro exam like we talked about. Pupillary asymmetry after a trauma, that should make sense. Worry about internal bleed or some sort of damage. Seizures, repeated vomiting, double vision, worsening headaches, can't recognize places or people, disorientation, slurred speech. So what do these all kind of sound like they could be concerning for? Like a stroke, right? So either deprivation of oxygenated blood to brain tissue or bleeding into brain tissue, right? So that's all concerning, and we'll tailor that for stroke. But these are definitely concerning signs. So, yeah, you star this one for me. So again, this is that, I think I gave you a couple of these last for the upper lower motor neuron, and I think there was one for Wernicke's and Baroque's. But I think this kind of makes it easier if you're studying. So delirium versus dementia. Again, I want us to learn it, 2 separate things, and then we can worry about crossing over and bleeding into each other later when we get out and practice. But you see your delirium is typically an acute onset, responds to at least some stimuli, can appear sleepy, disoriented, inattentive, level of consciousness may be impaired, any age, typically reversible, and then you can contrast that with your dementia on the other side. I'm not going to read it for you guys, but I think the key there is typically it's chronic over time and it's irreversible if you got issues there. So key elements of your history, your time course, chronic is obviously dementia, subacute, acute, and delirium. Yep, we already talked about a little bit. So an acute change in your mental status by definition, become delirious. Okay, this could be hours to days of disturbance of consciousness, and this is going to be caused by an underlying medical cause, such as, you guys kind of named some of them, infection, right? Metabolic derangement or disturbances, okay? So those type of things. Hallmark description is waxing and waning levels of consciousness. Underline that for me. So hallmark description is waxing and waning levels of consciousness. If I give you a patient, right? If I give you a patient and I'm trying to get you guys to delineate between delirium and dementia, and I put that they have waxing and waning levels of consciousness, I'm trying to get you guys to go with delirium, okay? I'm not trying to trick you. Key features, once you guys look those over. Select causes, a lot, we've kind of talked about these a little bit, but so stroke was the one that's obviously the one we want to rule out quickly. We said it was reversible. Is stroke reversible? Maybe. Maybe. Time is tissue, right? Yeah. So it would behoove us to figure it out quickly. Yeah, some of your stroke patients can regenerate, and you guys can get some of those deficits back. Sometimes you can't. That's a loaded question. You're welcome. That's a guess what I'm thinking question. I'm never a fan of those. Alcohol, drugs, yeah, drugs can be reversible. Opioid, the fentanyl crisis that's going on. Patients come in obtunded or altered. What happens when you give them a couple sniffs of Narcan? They wake up wanting to fight you, yeah. They wake up and say, "Thanks for saving my life, Doc, I appreciate it." No, they're like, "You ruined my high, you MFer," and you're like, "What?" Anyways. Doesn't always happen. Sometimes grandma overdoses on her opioids by accident from polypharmacy, but my drug addicts are usually pretty upset that I ruined their high. So, okay. Alcohol, so lifetime risk of serious alcohol problems, men greater than women. It's a depressant, right? So, think about how alcohol works. So someone tell me, you don't have to read all this stuff. So when I drink copious amounts of alcohol, what does it do besides make you feel fantastic? So, well, this is, yeah, so initially it's going to suppress my CNS, right? So my neurotransmitters, which one specifically? So it does a couple things. You guys should think back to your 4-day weekend a little while ago. So we remember GABA as an inhibitor, right? So it increases some neurotransmitters and it decreases some. I want you guys to think about GABA, which is your major inhibitor. So by drinking alcohol, it increases GABA. So if I'm increasing an inhibitor, what's the effect?
Decreases.
I'm down. I'm going down, right? I'm relaxed. I have slurred speech. I can't walk, right? All that stuff. A couple beers feels great. Half a bottle of Captain Morgan's doesn't feel too good, right? Well, it depends on who you are. And there can be, this isn't like a strict linear construct, right? Some people in here may be able to hold their alcohol and drink a half a bottle of Captain Morgan's. That's not good. You shouldn't do that. Some people may do that and they may die, right? And that's also not good. You shouldn't do that as well. But you can develop a tolerance on certain things. So with your specifically alcohol and neurotransmitters, you drink enough alcohol, you increase GABA, which inhibits your CNS, right? Long-term drinkers, short-term binge drinkers, you stop drinking, it decreases GABA. What happens then? What happens if I have all this inhibition and I'm drinking chronically every day, half a bottle of vodka, and I have all this inhibition and then I just stop? What's going to happen?
Regret your life choices.
You regret your life choices. So everything's going to turn on pretty quickly, right? So everything's going to turn on pretty quickly, meaning my neurotransmitters, okay? So if all that inhibition is gone, what's happening in my CNS? Overexcitation. What happens with overexcitation we talked about yesterday? Seizures, right? So I'm going to be agitated. It has the opposite effect of what alcohol does for normal people. It cools them down, chills them out, probably lets you mellow out a little bit. But when an alcoholic stops drinking, they start shaking, they get agitated, they sweat, they start going into delirium tremors, or you may have heard of as the rum fits, which is old school, and that's seizure disorder. That's concerning. So you guys got to understand that. They can present with nystagmus, dysarthria, limb and gait agitation, and the alcohol level doesn't necessarily predict your symptoms, right? So I pull alcohol levels on these people when I see them in the ER. Why? Because I can't discharge them at an unsafe level. What happens when I take somebody that comes in with a 350 alcohol and I discharge them at 300, they walk outside and get hit by a car. Who's liable for that? Me, right? So you have to make sure that they're at a safe level. That's why we pull alcohol. I've seen some of these alcohol levels, 350, 380, 400s on people that would probably kill anybody in this room, and they're like walking around. It's pretty crazy. So what do we do with them? We want to stabilize them and monitor for withdrawal symptoms, like we just talked about. There's a CWA score. I'm not going to make you guys memorize that. It's something that you want on your phone, again, and just look it up, and you would look for headache, agitation, shaking, sweating, those type of things. You'd be able to get an objective finding for their CWA, C-I-W-A. What in the heck does it stand for? Does anybody remember off the top of their head? I should know this, but I don't. Continuous Clinical Institute Withdrawal Assessment for Alcohol. So I don't memorize that stuff. I don't remember the questions, but when you go in your EMR, you can ask that, or you can put in an order for like your nursing staff to do CWA assessments every 2 hours, every hour, to make sure that they're not getting worse. And the higher that score, the worse they're getting. So we won't play with that. It's not testable, but I think it's important. Alcohol withdrawal, shakes, anxiety, tachycardia, agitation. Ask them their last drink. When was your last drink? About 5 to 10 hours after their last drink, we might see symptoms. Peak 2 to 3 days, and then improve at 4 to 5 days. Delirium tremors, the shakes, the seizure, right? They can become delirious, and then treat them with benzos, right? So treat them with benzos. Why benzos? What effect does benzodiazepines have on the brain? What does it do to GABA?
Or downward.
GABA is an inhibitor. It increases GABA, just like alcohol, okay? So benzos, and I'm not talking about 1 milligram of Ativan. These folks are probably heavy hitters with this. Their brain chemistry is probably off, so they may need 2, 3, 4, 5 heavy doses of benzos. And I would encourage you, practice how you want, but early and often, if I start seeing people shaking, agitated, and sweating, that's not the time where I'm like, yeah, I'm really concerned about benzo overuse. I'm like, let's give them 10 of value before we really do anything and calm them down, right? So you're taking a risk. Maybe they take it and run out the ER. Aha, I got him. That's left without being seen or AMA, so still get hit by cars. All right, nutritional disorders, B12. We talked about these folks before, right? Pernicious anemia, gastric bypass. We talked about vegetarians, alcoholics, okay? Chronic use of acid blockers. Anybody on a chronic PPI? Anybody have GERD? Just old man me, just always burping and no. So chronically taking protonics every day. So maybe I haven't checked B12 in a long time, but and then if you find they're deficient in B12, just supplement them, okay? Wernicke's encephalopathy, right? Thiamine is the most commonly, deficiency is most commonly in chronic alcoholics. You can see that characteristic triad, ophthalmoplegia, nystagmus, so eye pain with movement, fluttering of that eye or that nystagmus, gait ataxia, and global confusion. So that's highlighted. Those triads are easy money. And then if they're thiamine deficient, we probably want to give them thiamine, okay? This is pretty easy. I think we talk about maybe I'm hallucinating. Yeah, so this talks about the relationship briefly about thiamine and glucose. I don't want to go back into biochemistry, that's in the past. You guys already passed that course, but what I'll tell you is that thiamine is super important for ATP production. Is that important for maintaining homeostasis and regular bodily function? Yeah, so if we're depleted thiamine, kind of where thiamine goes, glucose is also important for ATP production, so glucose is probably down as well. If we give thiamine without considering glucose, then we can deplete that glucose further, and then the result of ATP is going to be lactic acid. So if you're producing lactic acid instead of ATP, you're basically throwing your patient into a lactic acidosis and making them septic, so that's not good. What's the so what about this, other than it's that's kind of neat, like 6,6H12 over 6. I'm like, we'll talk about molecular. I don't really care about all that stuff. For your alcoholics, order a banana bag, okay? I want you guys to remember that if you hadn't talked about it. Banana bags have glucose and thiamine already pre-dosed for you. So you don't have to do too much mental math on this. If you're thinking about an alcoholic that's coming in, right? In addition to ordering that judicious benzodiazepine, I'm already ordering a banana bag. And I'm not calculating out like how much thiamine and glucose. Banana bag, baby. Give them 2 of them, I'll come see them after it's in. And they gotta drip that in slow, so. I usually admit my alcoholics to just to medicine because this isn't something I'm going to turn around in a 10 to 12 hour shift. So, all right. Further precipitation down this. So later on, deficits in learning and memory. You get this Korsakoff psychosis, something you see with chronic alcoholics with Wernicke's encephalopathy, and that's gaps in memory, confabulation, and disorder of temporal sequencing. So. I really never have stopped and said like, oh, I wonder if the Korsakoffs is accompanying their Wernicke's. Like, usually they're altered anyway, so it's hard to determine. All right, a little bit on dementia. So you can have different types of dementia. We'll talk about MCI, Alzheimer's, vascular dementia, FTD, and then dementia with Lewy bodies. And then I think we're done after that. So, all right. By far, Alzheimer's disease, 50% of dementia in Western society. So you guys, I know you're like, well, 18 to 35-year-old healthy male, female population. You'll see this when you practice outside. This was a blind spot for me. Like my demented patient group, like other than my grandparents that are now all deceased, you'll see 70, 80. I had 2. What do they call them? Centurions? So I had a 100 and 101-year-old were like my first 2 patients on Sunday. I'm like, damn, that's, don't breathe too hard, like, you know, blow them over or something. But they were 100 and 101 and they were like mentally with it. I'm like, God bless them. Anyways, so something you got to consider in your older population. So the hallmark of the diagnosis, progressive intellectual decline, okay? Not due to delirium. So we have to rule out another cause that could be changing their mentation, right? So we have to do labs, we have to do a urine, blood work, we have to make sure they don't have a brain bleed, something we can reverse before we can go down the diagnosis path of dementia. Does that make sense? Age is the main risk factor. Age, circle that. If I ask you, you guys should all get it right. Mild cognitive impairment, so memory problems, short-term, most common, right? Does not impact function. Definition is falls 1.5 standard deviations below normal in your standard memory testing. So no medication will delay progression to Alzheimer's disease. So mild cognitive impairment is kind of like a mild form of Alzheimer's disease, but it usually progresses to that. And by definition, you guys can see there 1.5 standard deviations. So mild cognitive, it often turns into frank dementia, usually Alzheimer's, like we said, approximately 12% a year. So again, it's kind of quick, I guess. Unclear why some folks get better and worse, and you can see there's some risk factors there. I don't think I'll have you memorize those. I mean, I think it's mildly interesting, especially if this is your bailiwick and you guys go into this field, but that memory deficit 1.5 is definitely diagnostic. Presence of ApoE, that's neat. I don't think I asked you guys that. Small hippocampal volume, low CSF, and then family history. So family history, 1.5, those are all pretty good. Alzheimer's disease, anybody directly or indirectly affected by this? Yeah, family members? It's a tough one. Yeah, it's a tough one. Care to share? No, you know, they put you on blast.
No, my great-grandmother, it was time for her to go home. She grew up and they had to light the lamp on top.
Yeah.
My grandmother woke up at 2 a.m. with the rag on the table on fire because she was trying
Dude, I knew you were going to go there, man. Damn, that's bad. Yeah. Yeah, same. My grandmother, it's in my family too. I think I told you guys this in CS2, but like nightgown, she moved in with my aunt like 3 o'clock in the morning, just walking around looking for last year's Easter eggs, like totally off her rocker. But yeah, it's scary, and you know, age is a risk factor, but so is hereditary. So hopefully we can dodge it, man. Yeah. Oh, the bracketing you in. I don't know. So. All right, so cognitive changes, generally speaking, so memory first, second one is language, visuospatial deficit, and then lastly is executive function and decision making. So, and you can get early, middle, late, end stage Alzheimer's disease, but again, I just want us to know that it's a progressive disease. Age is the major risk factor, so 70 or older. Family history is another one. Diabetes increases it by 3%. Why do we think diabetes increases this by 3%? What? Yeah, crystallizing of brain tissue. I'm good, right? So this is actually has been referred to as diabetes type 3, which are like, huh? But some of the literature now refer to like Alzheimer's as DM3, and you'll be like, what is that? Like, it's not. I don't know if it's universally accepted now, but that crystallization or that glucose molecule that our brain needs to function, too much of a good thing is a bad thing. So like. You're tired, you guys are all healthy, you snap into a Snickers bar and you feel pretty good, right? You're like, wow, I feel like I'm awake. You sit at your home all day and play video games and eat Whataburger 17 times a day. Probably not the greatest lifestyle for you. So you start getting plaque deposits in your brain which affect your cognition. So diabetes increase by 3-fold. So. And then the major genetic risk factors at ApoE but I don't know, it's kind of interesting, but I don't know that a lot of folks that are doing genetic testing for this. I shouldn't say that, but we won't be doing it. Family medicine will refer them out to a geneticist for that. So, like we said, early stages, memory loss, but it interferes with your daily activities, right? So the ADLs of getting dressed, brushing your teeth, toileting, feeding yourself, it's starting to interfere with those. Question? Or you just conducting? Nice. Anosognia, so lack of awareness. So these patients probably don't know that this is going on. Who's bringing them in? Family. Yeah, family members or someone that's living with them. Maybe a close friend, but usually loved ones. We'll just leave it at that. So, middle stages and late stages. I'll kind of pause for you guys and let you look at that. Think if there's anything we really want to say. That late stage, sleep, wake, wandering, so that was kind of Grandma Rogers, right? Kicking cans down the street. Delusions, nurse is stealing my blank, right? But these are a vulnerable group too, right? So they're in a nursing home and they're saying everybody's stealing them out together because they have delusions, but what if somebody's really doing it? So one of the most vulnerable populations are elderly in nursing homes. Right, for either sexual assaults, thefts, stuff like that. So when they say these things, consider it as a possibility. Don't just brush it off and say, oh, you're crazy, right? They're old, so there's no way this could be happening. I bring that up because I had a simple question on the pants. I looked at it and was like, but it was an elderly patient that was living with her family and was coming in and complaining that the family was keeping her bound and shackled to just get her Social Security money. And they said you highly consider dementia in the differential, but in your physical exam you actually see like ligature marks, and it's like, what should you do? It's like send her home. Like, it's just crazy. Admit her. Call the social worker. Like, call the police. And I'm like, yeah, probably want to get somebody involved because. Like if they have physical exam findings, like they're getting shackled, like that's a concern, right? Your boy got that one right. So. I was like 1 for 1. Keep them coming. But anyways, all right. End stage: rigid, mute, incontinent, bedridden, hyperactive DTRs, monoclonic jerks, and then death. Usually secondary to aspiration, malnutrition. They usually get an aspiration pneumonia. So as you choke on something, they get sick, septic, and die. So they're really just. It's terrible. They deteriorate right before your eyes. They don't really know it too much and aren't aware of it like some of our other pathology, ALS. But this is rough. This is a rough one to watch. So let me see. Typical duration, symptomatic to we're getting better. We can slow some of this down, some of our newer meds. I'm not going to quiz you on that, but I want you guys to know this is a progressive disease that usually ends in death. Everybody all right? Push or hold? What do we, how's the temperature? All right. It's cold. Macroscopically, temporal degeneration, so you can see those deep sulci in there. Microscopically, so plaques and tangles. You guys aren't pathologists, but again, if I give you a question or a stem and you hear plaques or tangles, right? Neuritic plaques or neurofibrillary tangles, those are protein deposits in the actual brain tissue. I'm not going to throw this slide up there, but I do think it's interesting. So again, we talked about, so what? What is sugar doing to contribute to this? So we're actually getting some protein buildup secondary to either hereditary, diabetes uncontrolled, so there are a lot of confabulating factors, or just getting old. So what happens to your brain typically when you get old? It atrophies. You say it turns to mush? No, that's just not that. No, it atrophies. So you could do a CT scan of a perfectly healthy, God bless you, 80-year-old and see deep sulci atrophy. That's probably normal to some extent, okay? Workup, we're going to look for a reversible cause, which would be delirium, right? So a cause of delirium, right? If we find it, we'll treat it. EKG, or excuse me, EEG, maybe normal, maybe possible slowing. CSF, normal. MRI, CT, could be just normal, right? So we gotta rule out a reversible cause before we can just send them, hey, it's dementia, sorry. We're gonna miss a million things that we didn't check for, but it may be true. Treatments, behavior mods, medical management. So behavior modification, build rapport, memory aids, decrease stress, baby proofing the house, right? So maybe putting, locking the cabinets, putting, trying to think of those doorknob things so they can't, get out or something like that. Please don't lock them up. Don't shackle them to the radiator. It's not a good idea. That's not what we're talking about here. Build rapport, memory aids. What are we talking about with that? Yeah, notes. So we see a lot of like early to middle Alzheimer's will put notes on things to remind themselves to do it, right? So they'll put notes or sticky notes all over their house to remind them to do things. And sometimes that can help, okay? There's a high caregiver burnout, right? There's adult daycares, support groups. There are some locally around here. I've seen like advertisement for them. Again, like-minded individuals going through the same thing. It's probably strength in numbers. So, treatment. Do you guys remember that take care of grandpa thingy-majiggy? Did they tell you that in farm? Maybe. I don't think I'm going to ask you too many questions, but that was something that I was just sitting here one day and I remembered it from IPAT OT12, but. I would say better than memorizing these medications in that top right would be when your patient declines or denies any previous medical history, and you look at those and you're like, Aricept, that's weird. Razotine, Exelon, like I don't know any of these medications. Just look them up and you'll see that they're usually primarily used for Alzheimer's disease, and be like concerned that they may either forgot that they had it, hence the disease process and pathology, or maybe they just didn't want to tell you because they were embarrassed or something. Anyways, some newer meds on the bottom there. I think I added that. So that's FDA approved in 2023. Monoclonal antibody, right? 27% reduction in 18 months of progression of this disease. So we're making strides in this. We're doing okay, but it's still progressive and usually 100% fatal. Vascular cognitive dementia, right? So this is going to be dementia arising from a vascular insult or a stroke, essentially. Lacks a uniform set of criteria, but secondary usually to a stroke, onset, or stepwise deterioration, focal findings on neuro exam, or infarct seen on imaging. So FTD, frontotemporal dementia. This is a group of clinical syndromes present to the 5th to 7th decade of life. There's 3 main types. We'll stop at number 1. Is behavioral FTD, which is by far the most common. Behavioral variant, social and emotional system dysfunction. It's a motor neuron disease, semantic and then non-fluent, agrammatic symptoms you would find. Anybody know anybody famous that has this? It's in the news. Bruce Willis, is that you say? You're 100% correct. Yeah, so Bruce Willis, and again, you know, sometimes your famous people get highlighted more because they're in the public eye, but I think they try to make it more of a private journey down. I think the daughter does some of the updates, if you will. But so yeah, he has FTD behavioral variant. Let me see if there's anything else I can say here. My notes. I think that's good. I would just know it's FTD is the most common. That's a good one to know. So, gross hallmark atrophy of the frontal and or temporal cortex and MRI, and then microscopically again. We talked about plaques and tangles. This is going to have a misfolded tau protein. Am I going to be able to look at a microscope and tell you what that is? Hell no. But if you hear misfolded tau protein, I would like you in your studies to kind of associate this with FTD. Okay, same for plaques and tangles. I won't give you a question that says, unless you want me to, a misfolded tau protein is pathognomonic for which pathology, right? And you would be like, FTD, yeah. We could do that if you want to, but I'd probably give it to you as part of a stem of the question. Treatment, again, high caregiver burnout, no therapies are going to slow it. This is progressive. Usually get visual hallucinations, Parkinsonisms, that shaking, fluctuant alertness, sleep behavior disorders, delusions. Oh wait, I'm just totally freak out on something else. All right, recycle that for a second. Let me take a step back, 15 seconds. This is a totally different from FTD. So this is a different type of dementia with Lewy bodies. I just started reading like a robot. You guys are like, that's not what you've been doing for the last 60 minutes? All right, so this is one of the last type of dementias we're going to talk about. Dementia with Lewy bodies. This one's pretty easily because microscopically you're going to see Lewy bodies, right? So if you see that, you'll be like, oh, it probably has something to do with Lewy body dementia. So. It's going to be characterized by visual hallucinations, Parkinsonisms, which is like Parkinson's disease, shaking, cognitive rigidity, which we'll talk about a little bit more later, fluctuating alertness, and sleep behavior disorders. Delusions are extremely common. I kind of read through that because we talked about delusions being common with FTD and Alzheimer's as well. So, but Lewy bodies are going to be throughout the brain. So all three of these has different microscopic buildups in the brain that shouldn't be there, which creates similar presentations. So treatment, cholinesterase inhibition, exercise, and antidepressants can help out. Okay? That cholinesterase inhibitor, just FYSA for your situation awareness, it does provide benefit by reducing hallucinations, stabilizing delusional symptoms, and even helping to slow some of this progression. But again, this is a progressive disorder. So. All right, last thing we'll talk about is some reversible causes of dementia, some things you need to consider before we slap the diagnosis of dementia on somebody. So you can see that it's a pretty powerful statistic. 1,000 patients, memory disorder, 19 had reversible causes, 81 had irreversible causes. So we need to make sure that we're making sure that this isn't a reversible cause. 3 most common reversible causes that masquerade: depression, hydrocephalus, and alcohol. So again, I'll tell you right now, if we're worried about dementia, a demented patient, should we screen all those patients for depression?
Yeah.
I'd say the answer is yes. How do you screen a patient for depression? PHQ-9, what else? Siggy caps, awesome. See, you're like, I flushed that down the toilet last semester, right? So you got to memorize, you got to kind of bring that stuff back up to the surface. So remember, if we have a demented patient, we need to make sure they're not just really depressed. And I've seen those patients too, which they're very tricky. So again, we call it reversible because we can treat it, but depression, normal pressure, metabolic disorders, medication, alcohol, and malignancy. 100%, just underline it. Depression is most commonly mistaken for dementia. All patients with suspected dementia must be screened for depression and anxiety. Ooh, I threw anxiety in there too. So do a GAD-7, a PHQ-9, or CB-CAPS, whatever you're going to do. So you're going to screen them reflexively. And again, I tell you guys this in academia, don't freak out if you're in the ER and you think they're demented or delirious on top of demented, confabulating the patient, and you missed it, right? Like, oh, I didn't screen him for depression. Damn it. Like, that's okay. What's called practicing medicine. We'll get better next time. Somebody like a hospitalist or neurologist is probably going to pick up on that. But it would be great if you thought about it too. Maybe you already did it. They would just be like, wow, that PA down there is, you know what, figured that out, that's good. Just like when you call them up with that altered patient and you have the MMSE score, they're like, you even know what that is? Most of the providers don't do those in the ER, but you guys are going to be different. All right, comparing by the each dimension depression, I think that'll help when you study, so just take a look at that. How do we treat depression? I was going to say, who gets CBT? He's my guy, man, so don't even worry about that. I love it. Everybody. So CBT, SSRI, SNRI, good. You guys already know that. Normal pressure hydrocephalus is a tough one to make. There's a classic triad here. Cognitive decline or dementia, urinary incontinence or urinary urgency, and then gait difficulty. So your patient's like peeing on themselves, can't walk right, and they're kind of they're declining cognitively. Weird triad, right? So the bladder disorder is a result of a hyperactive detrusor muscle due to reduced or absent central inhibition, which I think is kind of neat because I had to know that. I'm like, well, I can understand like if they're becoming delirious or demented, they're having problems walking and thinking, but why just start peeing on yourselves, right? So you got to kind of throw that in there as well. So that's a very unique triad to consider hydrocephalus, but it's a tough one to make. CSF pressure normal, neuroimaging, you see larger than normal ventricles with little or no cortical atrophy. Triad that we just talked about on those findings, and then management. So essentially these folks have big ventricles, normal pressure, but excess CSF fluid floating around, so they're going to do a VP shunt. So a ventriculoperitoneal shunt from their head into their stomachs and some of that. Not us, we're not doing that. Neurosurgery is going to put that in so they can drain. I have not caught one of these by myself. I usually see them come in with the diagnosis previously, and we're worried about that VP shunt being either clogged or something, or maybe it's not working. So you get some imaging of their head, of their neck, and their chest, or their abdomen, and make sure that it's patent, not kinked off somewhere, isn't dislodged. And if it has, don't touch it. You're not fixing it. Just call them. Call a neurosurgeon. Be like, hey, your tubey thing, your straw from their head to their belly, it ain't working. They'll be like, what? But all right, we're almost there. Sorry, guys. I'm at 48 minutes. By the letter of IPAP, I should have given you a break. Do we need it? No, we're so close. All right, vitamin B1, thiamine, we already talked about. Confusion, ataxia, diplopia, right? We talked about this already. Thiamine, but need to consider glucose, or what already has glucose in it? Banana bag, right? So you don't even have to do the mental math to it, but please give that a consideration before you do, or your patient will start producing lactic acid and then develop a lactic acidosis, which is not good. So, B12, same thing, consider pernicious anemia, right? If they're depleted in B12, let's give them some. What do you think of that? Amazing, yeah. Cancer, this is kind of one of the reasons why we do neuroimaging, right? So my altered mental status, patient that comes in, right? My workup I'm considering dementia versus delirium. I get a CT without contrast. I'm looking for a secondary lesion. I'm looking for a primary lesion, a mass-occupied lesion that could be changing their mentation. You guys think if I have an expanding mass in my head, getting bigger in a confined space, it's going to change the way I act, the way I think? Yeah, absolutely, right? Rhetorical question. So that's why we're doing that CT with non-con. Everybody throws shade on your ER providers because they're like, you'll CT everything. Maybe it's warranted, and maybe I can articulate why. So, medication, do a med review, right? And then figure out if there's some sort of medication reaction going on. Well, how do you do that? You guys are supposed to know everything. That's what we tell you guys here at IPAD. We try to scare the crap out of you. You're going to be out there practicing by yourself, right? I don't. I think it's a team sport. So if you don't know, ask. Go find your PharmD and be like, hey, look at these meds. This person's demented or delirious. Is any of these meds causing that? Ask them. Well, what else could I do? Check out my phone. Do you guys have any farm checkers in your phone? Lexicon, Medscape, anything like that? Use it. Use it. Put all their meds in there and see it's going to be like red, like will cause delirium, dementia. You're like, oh God, like that's telling you something. You don't have to memorize all this stuff. when you're out of here? Like, maybe you do. I don't know what they're teaching you guys in farm, but it always drove me crazy. Because if I don't know a medication or I look up a patient and I forget what it is, I look it up. That's what you should be doing. It's called practicing medicine, and it's a journey. Like, you should never stop trying to learn. If you try to memorize all the new meds, you're going to go nuts. Enough of that. All right. Again, kind of rehashing some of this we said already, but identify and treat reversible causes. Remove sedating meds that could be creating the situation. Look for depression. Always got to screen them. Study this slide. This is the second time you've seen it. So again, I think this kind of helps. Acute versus chronic, reversible versus not reversible. Some key points here. Alter mental status without obvious cause needs a full workup. So an AMS patient coming into the ER is absolutely a blank canvas for you. CBC, CMP, shotgun labs, neuroimaging, chest x-ray, right? Look for something that could be causing delirium or dementia. Keep your differential VAS. That was good, man. That was nasty. Whew. Anybody catch that? No? That was just a disgusting, fiery burp. All right. Delirium, treat the underlying cause, find it, reverse it. The hallmark of delirium is that waxing and waning mental status. Alzheimer's by far the most common in Western society. You guys will see it, maybe not in the active duty population, but outside you will. Risk factors are family history of being old. And that's it. You guys want to do this again tomorrow?